Welcome to the deep dive. Today, we're really getting into some specialized areas of mental health. We're looking at where the mind and body intersect in really complex ways. We've gone through material covering genetics, hormones, trauma, even spirituality, pulling out the key knowledge nuggets for you.
Yeah, and the big picture that emerges right away is just how interconnected everything is. It's always this sort of bidirectional thing.
Not just brain impacting body, but the other way around, too.
Exactly. You've got biology affecting psychology and psychology messing with somatic functions. That interplay is really the theme for today.
Okay, so let's start right there with psychiatry and reproductive medicine. That seems like a prime example of this two-way street. How do we actually distinguish those directions in practice?
It's a really crucial distinction. So when biological changes, like, say, hormone shifts during the menstrual cycle, directly cause psychological symptoms, that's what we call a somatopsychic disorder.
Like PMDD?
Precisely. Premenstrual dysphoric disorder is the classic example. The hormones trigger severe mood shifts, anxiety. It's biologically driven.
Got it. And the reverse, mind affecting body.
That's psychosomatic illness. The origin is essentially in the brain, maybe stress, emotional conflict, but it leads to real changes in how the body functions.
And a key example there would be functional hypothalamic amenorrhea, FHA.
Yes, FHA is a perfect illustration. Clinically, it shows up as missed periods amenorrhea for 3 months or more, or maybe just really long cycles over 45 days.
And its functional meaning, no physical cause.
Right. It's a diagnosis of exclusion. You rule out tumors, PCOS, thyroid issues, all that. What's happening is that chronic stress, often combined with things like intense exercise or significant weight loss.
Metabolic stressors.
Exactly. Those signals basically tell the brain, specifically the hypothalamus, to dial down reproductive functions. It reduces the pulses of GnRH needed for ovulation.
So the brain's stress response effectively hijacks the body's normal hormonal controls.
You got it. And because the root cause is often behavioral, the stress, the diet, the exercise, fixing those underlying factors is key to recovery. Medication alone usually won't restart the system.
Okay, sticking with the reproductive timeline, adolescence. The material points to a really dramatic gender shift in depression risk around puberty.
Oh, it's incredibly consistent in the research. Before puberty hits, boys might actually have slightly higher rates of depression. But once puberty begins,
Things change fast.
very fast. There's a sharp rise in depression among girls. By the time they're 15, girls are twice as likely as boys who have had a major depressive episode. And the key thing is it tracks at the start of puberty, not just getting older chronologically.
Wow. Okay, now shifting gears to later in life, infertility and art-assisted reproductive technology. The emotional toll is immense, obviously, but there was one comparison that really stood out.
Yeah, it's quite jarring. Studies find that infertile patients often report levels of anguish and distress that are comparable to patients who have just received a new diagnosis of AIDS.
That really puts the severity into perspective, doesn't it?
It absolutely does. It highlights the profound grief and loss involved. And then the RT treatments themselves, while offering hope, they bring their own psychological burdens.
Like what specifically?
Well, there's often a loss of intimacy. Sex becomes scheduled, clinical, separated from conception. Then you have the sheer invasiveness of the procedures, the often huge financial cost.
Right.
And if the treatment leads to multiple fetuses, couples face the incredibly difficult, ethically fraught decision of selective reduction. That's a massive psychological weight.
Okay, let's move from that very personal level stress to something much broader. Crisis and disaster situations, war, terrorism, natural disasters. There's a kind of pattern to how people respond, isn't there?
Yes, there are generally recognized phases. Right at the moment of impact, you get the impact phase. People are often in disbelief, maybe numb, definitely experiencing intense fear. These are expected reactions.
Normal responses to abnormal events.
Exactly. Then comes the heroic phase. Everyone's focused on immediate rescue, survival, helping others. It's very action-oriented.
And after that initial push,
That's when the reconstruction phase begins. And this is the long haul. It can last for years. It's about rebuilding lives, communities, and hopefully finding some kind of post-traumatic growth, developing resilience.
in those immediate moments, though, psychological first aid, or PFA, is the go-to intervention. Can you break down the core principles? What are we actually doing with PFA?
Sure. PFA isn't therapy, it's more of an evidence-informed support framework. It boils down to about 5 key actions. First, enhance safety, both actual physical safety and the person's feeling of safety.
Okay.
Second, promote calm. Help people stabilize their emotional state. Third, foster self-efficacy, help them feel capable again, often through practical assistance, connecting them with resources.
Makes sense.
Fourth, enhance social connection, linking people with loved ones, community support. And finally, instill hope. Help them believe recovery is possible. It's about stabilizing and empowering.
Whether it's a large-scale disaster or interpersonal violence, like assault, the research points to one factor being overwhelmingly protective against long-term mental health issues. What is it?
Social support, hands down.
Really, that definitive?
Yeah, the evidence is strong and consistent. Having good, positive social support is the single biggest buffer against developing PTSD, depression, anxiety, or substance misuse after trauma. Connection matters hugely.
So thinking about survivors of, say, sexual assault or domestic violence, if they come into an ER, maybe initially just for a physical injury, what are the absolute priorities for the clinical team?
Well, obviously the medical treatment first, but beyond that, safety assessment is paramount. Is the person safe now? What's the ongoing risk? Clinicians also must be aware of mandatory reporting laws, which can vary.
Yeah.
But critically important is creating a safe, non-judgmental space and respecting the patient's pace.
Meaning they might not disclose the assault right away.
Exactly. They might present just with the physical injury. The clinician needs to be sensitive, build rapport, and address the assault aspect only when the patient feels ready and safe to do so. Pushing too soon can be re-traumatizing.
Right, that makes sense. Let's pivot now to some of the underlying biological factors, starting with psychiatric genetic counseling. That sounds complex, given that mental illnesses aren't caused by single genes.
It is complex and delicate. The counseling isn't about giving a definitive yes or no answer on getting an illness. It's about helping people understand the potential genetic contribution, how it interacts with environment, and how to adapt to that knowledge psychologically and within the family.
So it's not like testing for Huntington's disease.
Not at all. For psychiatric conditions, we talk about empiric risk. That's basically the average risk of recurrence seen in large population studies for, say, siblings or children of someone with the illness. It's a starting point.
But averages only tell you so much. Are there signs, sort of red flags, that suggest an individual's personal risk might be higher than that population average? Things that point to a stronger genetic loading?
Yes, there are definitely factors that tailor that empiric risk. Key red flags would include things like a very early age of onset for the illness, or particularly severe illness, maybe resistant to standard treatments.
Okay.
And of course, a heavy family history, multiple affected relatives across different generations. Those kinds of patterns suggest the genetic component might be playing a stronger role in that specific family.
That raises ethical questions, though, doesn't it, around testing, stigma?
Absolutely. There's potential for increased stigma, maybe pressure from doctors to take preventative medication, even with uncertain risk. And sharing genetic information within families can be incredibly fraught. It's a minefield.
Okay, shifting from genes to maybe augmenting treatment, micronutrients. There's so much noise out there. If we only look at meta-analyses of randomized controlled trials, the highest evidence bar, what actually holds up? Let's start with vitamin D and depression.
Right. For vitamin D, the meta-analyses show a moderate effect size for improving depressive symptoms in adults, so it helps.
But is there a catch?
The key nuance is who it helps most. The benefit was significantly clearer in individuals who were actually deficient or insufficient in vitamin D to begin with, so it seems to work well as a correction for a deficiency rather than a general mood booster for everyone.
Okay, that's clear. What about omega-3 fatty acids? They're everywhere for mood support.
The overall picture for omega-3s in major depressive disorder is a small but statistically significant improvement. So, again, there's something there.
Yeah.
But the really critical finding, the knowledge nugget here, is about the formulation. When they analyzed studies based on the type of omega-3, the EPA major formulations stood out.
Meaning mostly EPA, not DHA.
Exactly. Formulations containing 60% or more EPA, typically doses up to about 1 gram per day of EPA. Those showed the greatest effect. And it wasn't small, it was a large effect size.
Wow, so the specific type of omega-3 really matters.
It seems to be crucial for depression, based on this high-level evidence. Just grabbing any fish oil capsule might not cut it. The EPA content looks key.
All right, finally, let's touch on approaches outside of conventional medicine, complementary and alternative medicine, CAM, and also spirituality. How does the field categorize these diverse CAM approaches?
It's a broad umbrella. The textbook groups them into about 5 categories. You have Biologic treatments, things like herbs, supplements, special diets, then somatic therapies, massage, chiropractic,
Okay.
then mind-body practices, which are huge now, meditation, yoga, tai chi, and finally two types of energy approaches, scientifically validated ones like light therapy and postulated subtle energy forms like Reiki or therapeutic touch.
Got it. Let's look at a couple of specific biologic ones. Same S-adenosylmethionine often pops up for depression. What's the solid evidence say?
Well, it's widely used, and some people report it works fast, maybe within a week. But the large systematic reviews, they paint a picture of inconsistent and often non-significant findings compared to placebo or standard antidepressants.
So not consistently better in the big trials.
Pretty much. The high-quality evidence isn't strongly supportive right now.
What about kava for anxiety? It has a traditional history.
It does. And some early studies were positive. But again, more recent, rigorous systematic reviews, especially for generalized anxiety disorder, find only modest effects. And crucially, kava was not superior to placebo.
So for GAD specifically, the evidence isn't compelling.
Based on current systematic reviews, no. It's hard to recommend it confidently based on that.
Given the sort of mixed bag with those botanicals, where is the exciting CAM-related research happening? What looks most promising?
Oh, without a doubt, it's in psychedelics. We're talking LSD, psilocybin from mushrooms, MDMA.
This is moving into the mainstream now.
It really is. There's growing evidence for rapid-acting antidepressant and anti-anxiety effects, sometimes lasting for months after just one or two guided sessions. And MDMA, in particular, is showing really promising results for treatment-resistant PTSD. It's a major research frontier.
Fascinating. Okay, last area. Spirituality and religion in clinical practice. Is there actually a biological basis for feelings of spiritual transcendence?
It seems so, yes. Neuroimaging studies have found a pretty consistent link. Decreased activity in a specific brain region, the right parietal lobe, is associated with a reduced focus on the self, on personal boundaries,
Less self-focus.
which is thought to be a key neuropsychological mechanism underlying feelings of connection, transcendence, being part of something larger, classic spiritual experiences.
So if a patient comes in struggling with their faith, it may be a loss of faith or questioning things, but it's clearly not a delusion or part of a mental illness, how does that get coded?
There's actually a specific DSM code for that exact situation. If it's determined to be a genuine spiritual or religious problem, not a symptom of another disorder, the code is V62.89, spiritual or religious problem.
So it's recognized as a valid focus of clinical attention, even if not an illness.
Correct. But it's important to add the flip side. When religious themes do appear as delusions within a mental illness like psychosis, that's generally associated with a poorer prognosis and more severe symptoms overall. So context is everything.
This whole discussion really highlights how interconnected everything is.
Absolutely. That's the core takeaway from looking at these specialized areas. Mental health isn't just in the head. It's tied into our genes, our hormones, our gut microbes, our traumas, our communities, our spiritual lives. It's the whole complex human system.
Yeah, that integration point is really powerful. It makes me think about something else mentioned in the source material, how social isolation is strongly linked to cognitive decline in older adults.
A very strong link.
So here's a final thought for you to consider. We define spiritual connectedness broadly, maybe connection to others, to nature, to a sense of purpose beyond oneself. Could actively enhancing that kind of connection be one of the most vital mental health interventions we have, not just for older adults, but across the entire lifespan? Something to think about. Thank you for joining us for this deep dive. We hope exploring these specialized intersections of psychiatry leaves you feeling better equipped and maybe seeing those connections a bit more clearly.